Thank you for joining us at the end of a Friday. Welcome to the ACNS Fall Course on Neonatal EEG. I'm pleased to share a great panel of speakers, and in honor of Montreal, that was to be our co-host this year, I've included one from each side of Canada to teach you how to recognize normal and abnormal neonatal EEG background in neonatal seizures, and how not to mistake normal neonatal patterns or artifact for abnormalities. There's just one change. The order for the case presenters is switched, with Dr. Ilana Pinchevsky closing our session. Please enter your questions at any time in the Q&A box, and we may answer some during the talks, but we'll definitely answer them in an approximately 5-minute question and answer session after the recorded talks. So we'll get started with, I'll introduce our first speaker on neonatal EEG background interpretation. I'm very pleased to introduce a world-recognized expert in neonatal EEG and seizures. Dr. Robert Clancy is a professor emeritus of neurology and pediatrics at the Perelman School of Medicine at the University of Pennsylvania and Children's Hospital of Philadelphia. He's done pioneering neonatal seizure studies, particularly with newborns in the cardiac ICU after major cardiac surgery. He is also a memorable and engaging teacher. I'm grateful to have learned from him and didn't even need to be at CHOP, and I'm very pleased he will teach you to interpret neonatal EEG background. Go ahead and roll the tape.
Good afternoon, everyone. This is Dr. Bob Clancy from Children's Hospital Philadelphia and Penn Medical School. I'm going to start off this session of neonatal seizures by discussing interpretation of the neonatal EEG background interpretation. I'd like to start by thanking the organizers, particularly Dr. Tammy Tushita, for putting this all together and for inviting me. Thank you, Tammy. All right, so here's what we're going to try to do. Most neonates who experience seizures are acutely ill from asphyxia, stroke, intracranial hemorrhage, and so forth. Therefore, their EEG backgrounds are likely to be abnormal. The most common type of EEG background abnormalities include excessive discontinuity, low voltage, and voltage asymmetries between the left and right hemispheres. Some also have pathologic sharp waves, in contrast to normal physiologic sharp waves, which can imply electrical irritability or instability, a heads-up clue to possible seizures on the horizon. Before we can interpret the neonatal EEG background, we have to be aware of their biobehavioral state and how old they are. It's pretty simple in babies. If their eyes are open, we consider them to be awake. If their eyes are closed, they're either actively or quietly sleeping. Of course, lethargic and comatose babies have their eyes closed, and there are some kids that you just can't determine. For example, they've been administered a neuromuscular blocking agent. They simply can't open their eyes, so we can't determine their state. We use postmenstrual age to judge the expected maturity of the EEG background. So biobehavioral state and postmenstrual age. The first topic will be continuity and discontinuity. And first we'll look at normal degrees of discontinuity versus abnormal degrees. Discontinuity is a prominent feature of the normal immature EEG, period. It's proper to think at this point about the thalamocortical connections. They're really just starting. Notice in the upper diagram that there's a neuron in the thalamus and it's projecting to the cortex. But if you look carefully, it's actually arriving at the subplate, not the cortex proper. By around 30 weeks, the thalamocortical connections are now both in the subplate and in the cortex. The reason I mention this is that the behavior, the electrical behavior of the cortex really is modulated and under control of these thalamocortical projections. Continuity and discontinuity is a simple description of voltage behavior. You can think of it as the EEG turns on versus turns off, where the EEG bursts high voltage versus low voltage. And discontinuity is very sensitive to the postmenstrual age and medical condition. So here's a schematic of a discontinuous record. You see that there's electrical activity, then it flattens. another burst of activity and flattens and so forth. In contrast, a fully continuous EEG has nonstop cerebral electric activity with no gaps. All right, this idea of discontinuous EEG from the cortex as a result of deafferentation of the cortex is well known. Now, this is a brutal procedure. This is old psychosurgery or the prefrontal lobotomy period. So even as far back as 1952, it was realized that when the neurosurgeon puts the ice pick into the prefrontal regions and swipes and severs that the EEG becomes burst suppression. More recently, I was interested to see that if you actually grow clumps of neurons in the lab, and of course they're just neurons, there's no thalamus, there's no projections from the thalamus to the cortex, and record the cerebral electrical activity from these little lentil-sized clumps of neurons, that it too is discontinuous. All right, this is an important slide. We're going to go through it. This is normal developmental progression of continuity. On the left-hand column is the EEG when the child's either awake or actively asleep. And on the right-hand side is the EEG when the child is behaviorally in quiet sleep. So if you look at EEGs before, say, 29 weeks, you notice there's really no conspicuous difference between the amount of discontinuity when the child's awake or dreaming versus quiet sleep. There's no special name for this. It's considered a primitive or primordial form. By around 30 weeks, you notice on the left that during wakefulness or active sleep, yeah, the record's still discontinuous, but it's more discontinuous in quiet sleep. And the early French neonatal EEG pioneers said this tracing is discontinuous or tracé discontinu. Same thing at 32 weeks. Notice on the left that the record's still fairly high voltage, but there are longer periods of continuity, fewer periods of low voltage discontinuity, and again, easy to tell the difference between wakefulness and active sleep on the left and the tracé discontinu pattern on the right. Around 36 weeks, two things happen. One is that in the awake or dream sleep state, that EEG is now continuous in lower voltage. The early French EEGers said this is an average activity moyenne, average, medium, not too big, not too small, not too fast, not too slow. On the right side of the table, though, notice that although the record's still discontinuous, now the tracing alternates between bursts of high voltage and lower voltage. Now, the interburst periods need to be at least 25 microvolts, and they said that the tracing alternates between high voltage, low voltage, high voltage, low voltage, and of course we know that as tracé alternon. In 40 weeks and thereafter, you'll see again that dream sleep or wakefulness is comprised of activity moyenne. But curiously, look how quiet sleep may start. At 40 weeks, it may start as tracé alternon and then segue into continuous slow wave sleep. Around 44 weeks, the quiet sleep is continuous slow wave sleep. And around 46 weeks, we first begin to see sleep spindles coming from the midline vertex. So here's how it looks. At the very top figure is an example of tracé discontinu, so a burst of normal cerebral electric activity, followed by a quiet period that's below 25 microvolts. Then we get the second burst of high voltage activity, followed by low voltage interburst. The middle picture shows tracé alternon, meaning that the tracing alternates between bursts of high voltage versus lower voltage. Then there's another longer burst of activity followed by a lower voltage interburst. And of course, continuous slow wave sleep is just like what we do. So higher voltage synchronized delta activity. So the message here is that discontinuity lessens with advancing postmenstrual age. Again, the top, you see the highlighted blue areas are the quiet periods, and by 36 weeks, they are fewer and less common, and again, full continuity by 44 weeks conceptional age. This is a diagram from my mentor, Barry Tharp. These were premature babies who had no clinical encephalopathy, had no intracranial hemorrhage, IVH, PVL, and so forth, and who were normal at developmentally normal at follow-up at age 2 years. Only their EEGs were used to define ranges for the interburst periods. So the ACNS has developed guidelines for this. I'm not going to read these to you, but they're there for your consideration. All right, let's take a little closer look. Here's a trace discontinu, again, low voltage burst, low voltage period, followed by higher voltage burst. The interburst periods are reasonably long and low voltage. Trace alternon, longer burst of activity, quiet periods, longer burst of activity, quiet periods, which means that we can use this to judge background abnormalities. So here's a full-term newborn, and if you look, those interburst periods are probably longer than you would expect. Here we have 1, 2, 3, 4, 5 seconds, 1, 2, 3, 4, 5 seconds. They're pretty flat. So no big deal. The actual EEG activity within the burst looks reasonable. I can't fault it in any way. On the other hand, this is unmistakably abnormal for a full-term newborn. Really flat periods here at the beginning. The bursts are well comprised. There's good stuff in there. Another long period of low voltage activity. So this would be considered moderately discontinuous. And of course, the granddaddy of them all is full burst suppression. This is invariant. No matter what you do, there's no state cycling, there's no response to external stimulation, and the interburst periods are under 5 microvolts. Our next topic will be EEG voltage, normal versus abnormal. All right, here's what I mentioned, activity moyenne. So this is a normal tracing. This is a child who's either dreaming or awake. I like to look at the transverse area. Transverse here meaning T3 to C3, C3 to CZ, CZ to C4, C4 to T4. So we're going to highlight this and take a closer peek. All right, so here we are. Here's that transverse. And what we're looking for is continuous low to medium voltage and mixed frequencies. Now, you'll also hear the term polyfrequency. I think literally the same thing. All right, well, there's some theta activity. Look at that, 1, 2, 3, 4. Okay, so we have theta. Down here, we have some delta. Over here, we have some faster activity, so there is a mixture of frequencies. So there's nothing wrong with a relatively low voltage EEG as long as everybody's showing up for the recording. Continuous slow wave sleep, as the name implies, is continuous, and it's slow waves, it's delta activity. Here in quiet sleep, the neurons have synchronized, so we're going to build up our voltages. And you might notice right here in the midline that there are sleep spindles. Now that remember, this is neonatal EEG, so it's compressed, so that may look fast to you, but it's actually around 12 hertz. ACNS has also published voltage amplitude guidelines for full-term neonates. And here again, I'm including this for your reference. I'm not going to read through all of this. The other aspect of abnormal background voltage are asymmetries. So this can happen in 15 to 20% of kids with neonatal encephalopathy, that the lesion is either lateralized or focal and so forth. And we defined an EEG asymmetry as a ratio greater than 2 to 1. All right, so let's look at some of these abnormal low voltage EEGs. Here you see that there's basically nobody's home. There are some small fluctuations that we can see. It's hard to know if this is respiratory, pulse, movement artifact, or real cerebral electrical activity. So they all look the same from that point of view. Let's take a look at an EEG snapshot for asymmetry. So to be fair, we have to compare homologous regions. So let's start by comparing the left versus right paratemporal regions. And I have to say, I don't see much difference between the left paratemporal and right paratemporal. The voltages look pretty similar, and the spectrum of frequencies also looks pretty similar. On the other hand, when we compare the left paracentral to the right paracentral, we can see an obvious difference now. And the question is always, which is the abnormal or the more abnormal side? Is something wrong with the left, or is there something wrong with the right? So let's take a moment to inspect the composition of the EEG in the left paracentral. Okay, well, we know you can get some sharp waves in the central region, but boy, here's 3 in a row. Here's a little cluster of spikes. Here's another spike. And maybe some of you spotted a positive temporal sharp wave on the left. So in this particular instance, I'm thinking that the abnormal EEG side is on the left, that the right side's normal, and that the left is abnormal because of the excessive negative sharp waves and spikes in the left central region and the left positive temporal sharp wave. All right, how do we then distinguish between normal and abnormal EEG sharp waves? Well, here's our old friend on coche frontale, which are frontal sharp waves. They have a very classic look. They are triphasic. They go up, down, and up. And notice that they're synchronized. In fact, if there were absent on coche frontale on the left, you would ask yourself, what's going on with the left hemisphere? Why is it not making its normal grapho element called on coche frontale? So we want them to be there. It's a good way of judging symmetry. There they go. The most common place for, quote, physiologic sharp waves are in the temporal regions. Here you see a nice example. This stands out from the background. We can't explain it based on stuff that happens before or afterwards. And also notice that we're in activity moyenne. The background looks good. There's nothing wrong with this. And here we go. The central region, less frequently, but definitely can also make physiologic sharp waves. Now, one word of caution, this is a normal, healthy kid in quiet sleep. And my point is simply that sometimes trace alternon, if you start really looking around, you see a lot of fast activity and spiky stuff. We're not benefited by judging sharp waves within the burst of trace alternon. Once this kid wakes up and goes back into activity moyenne, all that sharpness is going to disappear. So our happy-go-lucky physiologic sharp waves can be en coche, frontal sharp waves, central region, and the temporal region as well. Here's an example of pathological frontal sharp waves. First of all, notice that the EEG background's quite low voltage. There's a paucity of, normal background constituents, and there's a whole run of left-sided frontal sharp waves. There's no way that this is normal. And just for extra good measure, we also notice that there's a sharp wave, a negative sharp wave, maximal at CZ, and that's really not a place where we tend to see physiologic sharp waves. Last thing to note is that recording an EEG in the neonatal ICU is very challenging. These kids are getting chest PT and ventilators and lots of handling and so forth. And so the electrodes can be jiggled and build up electrical capacitance charges. Now, these are recognized by the fact that the sharp waves, which are electrodes discharging their electricity, go straight up. They shoot up like a rocket. Real EEG sharp waves take a moment to reach their maximal negativity, as you can see here. So this is the easy way to distinguish between them. So in summary, what are the physiologic sharp waves? So the EEG tends to be normal. These are sharp waves, not spikes. They're most popular in the temporal regions more than the centrals, also on cause frontale, and they tend to be single discharges. There's one and done. On the other hand, pathological sharp waves commonly, but not always, the EEG background's abnormal. And yes, they can be sharps, but they can also be spikes. They can show up anywhere they want, including the midline vertex and occipital regions, and they're prone to recur in runs. Well, that's all there is, and we welcome our next speaker.
Well, that was really a fantastic talk. I always enjoy hearing your EEG expertise. It was great to have that sprinkled with some history too.
I'm the guy for history. Thank you.
Oh, love it. You should. Have you written a book on that?
Nah.
That'd be great. I was curious, would you also be cautious about overinterpreting sharp features with a trace discontinu pattern?
Well, it's actually an excellent question, Tammy. So this was meant to be a 25-minute talk, so I wasn't really able to delve into like what makes up the EEG background. And to the best of my experience, when the preemies have trace discontinu, the bursts are typically the things we all know about. We know about delta brushes, even those encoche frontale show up around 32 weeks post-menstrual age. There's a lot of rhythmic activity in the back of the head. So monorhythmic occipital delta activity, monorhythmic occipital and temporal theta activity, but it's not particularly sharp. So when you see the burst, it just looks like normal stuff, like things we see all the time. It's only in a subset of the older kids who fall into quiet sleep and show a trace alternon background that every now and then it's like, where did all this sharp activity come from? It's crazy. Mm-hmm. And then like the nurse comes and does something and they wake up and it all goes away. So, when you look at these recommendations for voltages and how many sharp waves and so forth, by and large, they're talking about studies that have looked at the EEG in active sleep or wakefulness when things are lower voltage. It's hard to get real specific about it, but long ago, we used to do EEGs on every kid with quote unquote near miss SIDS or Alties or Bruies or things like that. And it was amazing how often, if you look at active sleep, they got sharp waves once a minute, once every few minutes, temporal, central, things like that. So, the guidelines really talk about the awake or active sleep portion of the EEG, not in quiet sleep.
Thank you. That's a really helpful clarification. I think it's very easy for those sharp waves to be overcalled. So I'm really
yes.
fun.
And the fact, epilepsy doesn't go away when you wake up, for example. So like if all that spiky, fast, sharp stuff disappears the moment they start crying, it makes you realize that, it's part of the background of quiet sleep.
Yeah. And I know I kept your time short because we had a request from last year to do more time on cases. So I do actually have one other question. I was curious as to, with some of the newer studies coming out, suggesting that a 24-week premature infant can have an IBI duration up to 60 seconds. I was curious what you thought about that.
Yeah. So that's not a new idea. Okay. And way back when, probably in the 1980s, a very famous child neurologist, Cesare Lombroso, looked at the duration of interburst periods. And basically, he found a handful of very young babies who had interburst periods, like a single solitary interburst activity of over 60 seconds. And yet at age 2 years, they checked out to be normal. And his point of view was that, okay, so 60 seconds interburst can be all right. And yeah, in that individual child, that lucky little preemie child came out fine. That doesn't mean 60 seconds is normal. It's like a lot of abnormalities. You can have a this or that on your MRI scan or a little slowing here and there and be normal. So I don't really accept that 60 seconds is strictly speaking normal, but it's not inconsistent with a good outcome. That's been known for a long time. And, I mentioned very briefly in the talk that the degree of discontinuity is sensitive to age and medical condition. So there have been plenty of studies where, like, a preemie with respiratory distress syndrome might get like a mucus plug and desaturate. And during that period of time, the interburst periods will increase, okay? But it's a physiologic response to like a temporary medical condition. So it's really hard to take a single snapshot on the EEG and say 60 seconds IBI and launch huge predictions on it. So if most of the bursts are 60 seconds, I'm so sorry. I can't buy that as being normal because it really isn't. But a single one hitting 60 seconds, it's like, whoever is free of sin should cast the first stone, right? That kind of thing.
Thank you for that. Context is everything.
It is. We've heard this all day long. I mean, Bill Tatum's talk was excellent about context. And it's like, we don't read EEGs in a vacuum. We read them in reality. So what is the context? We got to know.
Thank you so much.
And Tammy, thank you for inviting me. I'm truly honored to have been invited.
Oh, honor is mine and our audience. Thank you.
Okay. We done? Yeah.
So to just try to keep us a little bit on time, our next speaker on neonatal electrographic seizure identification is Dr. Jeanette Milo. She's an assistant professor of pediatrics in the Division of Pediatric Neurology at the University of Alberta, Canada, and co-leads the Neonatal and Pediatric Neurocritical Care Service at Stollery Children's Hospital. She's developing their neonatal critical care program and is most interested in neuroprotection in neonates with critical congenital heart disease. She'll share with you today her passion for neonatal seizures. And we'll roll the tape.
Thank you for the opportunity to discuss neonatal seizure detection on EEG today. I have nothing to disclose. My objective for you today is to show you how to detect seizures on EEG and to discuss the effect of common anti-seizure medications. I will show you common NICU artifacts and how to detect them. And I will tell you how can we use EEG for outcome prediction. Let's start with how to detect seizures on EEG. And I think this is easiest to illustrate on a case scenario. The patient is a neonate born at 41 weeks of gestational age with forceps-assisted delivery, with APGARs 3, 4, and 5. And at 15 hours of life, the nursing staff noticed episodes of apnea and reported some bicycling-like movement. On the exam, the tone is diffusely decreased. So would we be comfortable diagnosing seizure based on the description of the event? And really, what the question is, how reliable is clinical diagnosis of seizures in neonates? I'll show you a video. You can see movements. The nurse is rocking the bed. You see lack of movement and something is happening because the tech is coming. So there's probably something on the EEG. Clinically, it's still really hard to tell what's going on. Although you might wonder about that right arm posturing. Now the nurse is alerted by the monitoring. And now he stopped breathing. Look at the posture. Okay. So this is his interictal EEG, quite unremarkable. And now, despite the artifact, you can appreciate sharp activity. You can see over the right temporal region. You can see the evolution of the activity. So the evolution of the frequency and morphology continues to evolve over the right side. And this is the point where the patient becomes apneic. This is at the end of the seizure when he becomes apneic. And this is postictal background. So although historically seizures were diagnosed clinically, growing evidence over last years have shown that clinical diagnosis of seizures is unreliable. The role of EEG in neonatal seizure diagnosis was also highlighted in the most recent classification of seizures and epilepsies by International League Against Epilepsy, which stated that neonatal seizures are really defined by EEG. And why it is so? Because there are many events and many movements that are not epileptic. And if we were treating all of those, we would expose many neonates needlessly to effect of medication with potential for neurotoxicity. We would increase sedation, delayed feeding, and therefore prolong their NICU stay. And since most of the seizures in neonates are electrographic, we wouldn't be able to treat what we cannot see. And untreated seizures increase risk of adverse outcome. And that's especially true if the seizures evolve in status epilepticus. Electrographic seizure is therefore an electrographic event with a pattern characterized by sudden, repetitive, evolving stereotype waveforms with beginning and the end. And this is very important because in the updated ACNS terminology, 2.5 Hz minimum frequency is no longer required as long as there is an evolution and clear beginning. and end. So this is a nice spike wave seizure example. This is a slow wave seizure. These are repetitive spike seizures. And therefore, the duration of the seizure has to be sufficient to demonstrate evolution in frequency and morphology and allow for the recognition of the clear onset, clear evolution, and the resolution of abnormal discharges. And the minimal time of 10-second seizure duration, which used to be required, is no longer required. Again, as long as there is that clear onset, clear evolution and resolution, it does not have to last 10 seconds. So I'll show you here, and another example is clearly some activity that is standing out from the background, is evolving. And this is the end. I'll show you another video. So there was something definitely suspicious on the EEG. There was clearly a seizure. Now let's see if we can see anything clinically. So this is a tonic seizure in a neonate with KCNQ2 pathogenic variant. And this is another seizure with, again, nice evolution of the spikes, sharp activity. And this is a neonate with a right-sided clonic movement and a left NCA stroke. And the clonic movements did not correspond very well with the electrographic seizure. They were sometimes 1 or 2 seconds, 3 seconds long, and the seizures electrographically were quite a bit longer. So again, it was very important to have an EEG for this one. So this would be a brief rhythmic discharge. And if we keep in mind the need for clear onset, clear evolution and resolution, we won't mistake rhythmic discharges for seizures. So continuous EEG monitoring is a gold standard in critically ill neonates. However, it is very resource intensive. And therefore, our main focus should be on high-risk neonates. So who are those high-risk neonates? So those are those with acute, either proven or suspected brain injury and encephalopathy. ACNS recommends EEG monitoring for 24 hours after the last seizure. So we are really looking for the 24 hours of seizure freedom. However, continuous video EEG is not always available. And we have to recognize that limited monitoring is better than no monitoring. Amplitude integrated EEG or AEG is a reduced montage EEG using single or dual channel, depending if we use 2 or 4 electrodes. And again, 4 electrodes are better than 2. The more electrodes we have, the better coverage of the brain we have, and a higher likelihood you will detect seizures. And another option is a serial routine EEG, which can be combined with careful clinical observation. However, we have to remember that if we are using serial routine EEGs, we will have long time, many hours in between recording, and there is a potential for hours to miss seizures. So if we are using amplitude integrated EEG, what will improve the seizure identification? So definitely, if the seizures either origin or propagate to the area where the EEG leads are placed, we will be able to detect them. And the most common leads are C3, C4, and if we are using dual channel, C3, C4, P3, P4 are commonly used. So again, if the seizure is around those electrodes, we'll be able to pick it up. Seizures that are longer in duration, higher in amplitude, are easier to detect on amplitude integrated EEG, higher seizure count per hour. And very important point is the experience of the reader. So the staff that is reading, the neonatologist who is reading EEG, truly the good training is necessary to avoid misinterpretation in an ICU. The experience is very, very important. And also when you're looking at AEG, we always should look at the raw tracing as well. The disadvantage also of the AEG, there is typically no video. So some of the suspicion activity, it's hard to rule in or rule out artifact if we don't have that video. Is also so that, and because of all this, it is important to recognize that AEG does not replace but complements conventional or continuous EEG for seizure detection. So for example, here, this is the amplitude integrated, this is the AEG band. So the seizure in the posterior head region over the occipital lead would not be detected, simply it's too far from the electrodes placed. Let's talk a little bit about the medication effect on EEG. So medication effect on EEG, one of the big one is the electroclinical uncoupling. And what is it? It means that clinical signs disappear despite persistent electrographic only seizure. So we cannot really see any clinical seizure, but they are still ongoing, and we will only be able to detect them if we have EEG. And both phenobarbital and phenytoin produce about equal rates of uncoupling. And it is a common problem. Up to 58% of treated neonates will have electroclinical uncoupling on their EEG. The effect of seizure morphology is also important to recognize. Phenobarbital will reduce amplitude and propagation of seizure, which is very important if we are using amplitude integrated EEG, because we have to be aware that seizures will be again harder to diagnose. Let's talk a little bit about EEG artifacts. Artifacts are very common in an ICU. An ICU is not an easy place to record EEG. And artifacts include non-physiological artifacts, such as devices that are around electrical phenomena, all the interference, as well as physiological, biological artifacts. In an ICU, rubbing, patting, sucking on soother, tongue movements, eye movements, those are all very common. So I would like to show you this example. And you may wonder, what is this arrhythmic-like activity? Once you notice this EMG activity, you probably start wondering if this is some sort of an artifact. And the best way to figure it out is to look at a video. And that's again the advantage of the continuous EEG versus the AEG. You just see the vigorous sucking, and it correlates nicely with your electrographic waves. Clearly, we are talking about sucking artifact. This is the video. So this was a sucking artifact, and it can look like this, just like intermittent delta waves. This is another one that can look quite suspicious, and almost wonder if it's some spike and wave activity, and you wonder if it has evolution. So again, what it is, the best thing is to look at a video. And I'll show you, this is quite at the end, so I'll show it to you. Now this is what's happening. The baby is being patted. So this was a back padding artifact, but it can look very impressive. And again, something that we wouldn't have if we didn't have a video. And the last thing I would like to touch on is, can EEG predict outcome? So increased risk of adverse outcome is suspected if the EEG abnormalities are persisting and they're diffuse and severe. So severely abnormal EEG definitely increases the risk of abnormal outcome, especially if it continues over time. Lack of sleep-wake cycling has also been associated with abnormal outcome. On the other hand, good prognostic signs would be resolution of EEG abnormalities, especially early resolution. So normalization of the EEG quickly or normal EEG from the beginning are definitely good prognostic signs. So let me summarize. Seizures are common in critically ill neonates, and they are difficult to diagnose. Seizures might be the only signs of CNS dysfunction. Most seizures are electrographic only. However, electrographic only seizures have similar pathogenesis and prognostic implication as electrographic seizures, and therefore should be treated. High-risk neonates, it means those with either proven or suspected brain injury and encephalopathy, will benefit from continuous monitoring. Continuous video EEG is the gold standard for neonatal seizure diagnosis. However, amplitude integrated EEG or serial routine EEGs are better than no monitoring. We also have to be aware of potential artifacts in NICU, and EEG background, especially EEG background over time, can help us with prognosis. Thank you very much.
Great. Thank you so much for that great introduction to neonatal seizures, and beware of artifacts. We have a couple of questions in the question and answer box. I will hand it over to you.
Thank you very much, Tammy, for inviting me. This is truly an honor. So the first question, how do you get EEG displayed on your routine EEG? Persis does this, that's true. We actually don't have Persis in all our NICUs. We have some NICUs with older native system, and we can display it there as well. It's on the bottom. There is just an option to lift the main panel, and we have it available. If you have older native system, maybe you can just talk to the IT or somebody who is responsible for your native system and get it displayed there. That's how we'll do it. And sometimes, honestly, I have an EEG on at the same time as EEG in some of the babies, because I find it very helpful when the neonatologist put their EEG on and I put my continuous EEG on it on top of that. I have both, and then I see the correlation. And if we need to remove, because we have NICUs where I cannot do continuous EEG always when I want to, but being able to correlate it actually helps me to see what is the correlation, how good we are picking up the EEG, and then I can show the neonatologists and the nurses, and we can go from there. So sometimes I simply just have both systems together. It happens. Or sometimes when the babies, especially cardiac babies, are very sick, I simply cannot use the whole head for the phone montage. I'm just doing it this way. So that's another option. I hope it answered your question.
Yeah, that's great. And it's quite, I'm glad you brought that up. There are quite a few EEG machine manufacturers that are now including trend software that can display amplitude integrated EEG along with your EEG in real time. So just talk to your EEG manufacturer about the capability for that and how to get it displayed.
Exactly. And the next question, what is the minimum duration to call electrographic seizure based on the new criteria? That was a good question. I was completely, I knew this was coming. So, and there is it's still a controversy. So 10-second duration was, it was suggested there is no need for having the 10-second duration. And of course, this was going to bring controversy and debate, and it's a good thing that it's debated. But I think if we are thinking about it, it's truly controversial either way, right? Because if we have 10-second duration, you have lots of real episodes that evolve and last 8 seconds, 9 seconds. Are we going to ignore them if they happen often every hour, right? Not really. And if you have something that lasts 11 seconds, but not 9 seconds, suddenly this will count this one, but not that one. I truly like the idea of having the sudden onset, evolution, and offset. And I think if we are focusing on that, I think that's truly more important than exactly the number. And I really like what Dr. Clancy mentioned about the sharp voice, everything in the context. For example, if we have a child with, for example, HIE, which we know how much they seize, they had lots of seizures, they've been treated, and now you have in an hour, you have even 12-second seizures. Are we really going to be that worried once we know that the seizure burden went down so much compared to a child that we have a new diagnosis, or we are just wondering if these are seizures? We have an EEG on to try to figure it out, and suddenly we have all these little episodes. Does it really matter how long they are if they have this a nice onset, evolution and offset. So I think the 10-second duration, as well as another change recently in ACNS recommendation, is to remove 2.5 frequency criteria. And again, it's about the onset duration, that truly that's something that stands out from the background, starts and goes away. That's how I feel. I don't know how you feel about it.
Yeah, no, I have a similar opinion. I'd actually be interested in also opening this question up to the rest of our panelists, Doctors Clancy and Yosowitz, because this is somewhat controversial.
Hey, it's Bob Clancy. Yeah, so the 10-second was arbitrary. The 10-second was arbitrary. There was nothing magic about it. And it tended to distinguish things like brief rhythmic discharges from quote unquote EEG seizures. But if you think about it, probably the only time you've seen brief rhythmic discharges are in kids who are also having seizures. So it doesn't like break the case wide open, nothing like that. So yeah, 9 seconds. I mean, based on what? What data says that one is right and one is wrong? But I agree with you, Jeanette, that it's like you have a bad background and all of a sudden some event shows up suddenly and it evolves, it moves, it changes its shape, it changes its amplitude, its frequency, and then it fizzles out. So what else can you call that other than a seizure? If it was 9 seconds, 9 minutes, it's a seizure.
Yeah, my only concern about, Dr. Alyssa Yosowitz, please.
I was just going to add, because I was part of the classification paper and we didn't want to say the 10 seconds. And so we kind of figured that's another paper. So it's not like the new recommendations, but we just didn't want to make this 10 seconds because it's totally arbitrary. Like 9 seconds, if it evolves, has a beginning and an end, it could be a seizure. And even epileptic spasms can be very quick and be a seizure. So we kind of just left it very broad to be followed up later on. But it's very, as everyone has said, there's no magic about 10. And that's kind of what we just made it broad and said it like that.
Yeah. And I think what everyone agrees upon is that you don't need a minimum duration if you have a clinical correlation. So
yes,
that duration goes out the window for that.
Right.
My concern is, there's patterns where you're not really sure if it evolves. I would be a little concerned if someone starts chasing and treating those, not so sure if they really evolve under 10-second patterns. And at least with having the advantage of continuous EEG, I've always seen, as Dr. Clancy said, that anyone who has something that evolves like a seizure under 10 seconds, before too long has definite seizures that are over 10 seconds that then allow me to act and treat. Perhaps it just becomes a lot more difficult if you're someplace where you're only able to get routine EEGs.
Right. Yeah, Tammy, those are rehearsal seizures. They have to get their energy up.
Fair enough.
Practice makes the meister.
Right. So agree. We have panelists, great question, great discussion. Thank you all. And we are actually also even staying on time.
Wow.
So without further delay, I'll move on to our third presentation. I'm pleased to introduce Dr. Alyssa Yosowitz, Director of Neonatal Neurology and Associate Professor at the Isabel Rapin Division of Child Neurology of the Saul Corey Department of Neurology at Montefiore Medical Center and Albert Einstein College of Medicine. She also, as you heard, has been busy as a member of the ILAE Neonatal Seizure Task Force, updating neonatal seizure terminology and classifying neonatal and infant epilepsy syndromes. She'll share some of that expertise with you today and her great cases. And without further ado, we'll roll the tape.
Hello, my name is Alyssa Yazowitz, and I'm Director of Neonatal Neurology at Montefiore Medical Center. Thank you so much for inviting me to speak today. I'm excited to speak to you about neonatal EEG and present some interesting neonatal cases. Before I begin, I want to define what I'm speaking about when I say term infant and preterm infant. So neonatal seizures in the term infant is defined as the first 28 days of life. In the preterm infant, this period extends to the 44 completed weeks of gestational age. Although neonatal epilepsy syndromes exist, they are quite rare, and the majority of seizures in this period are due to an acute event, so an acute provoked or symptomatic seizure. In 2017, Fisher came up with a classification of the epilepsies, which you're all familiar with. So this classification system did not specifically pertain to the neonate. So the difficulties with this classification in terms looking with a neonate is neonatal seizures are not generalized onset. Therefore, we don't know if they're unknown because they're not generalized. They're not focal to bilateral tonic-clonic. They cannot speak to us, so we don't know if they're aware or have impaired awareness. We also don't know if neonates have cognitive, emotional, or sensory symptoms associated with their seizures. And since they can't stand or sit, they don't have atonic seizures. So a neonatal task force was created from the ILE to put together a classification system for neonatal seizures. Earlier this year in February, our classification was published in Epilepsia. So what this classification did was it took a baby who had a clinically suspicious event and did an EEG right away. So anything without an EEG correlate was not classified. And we only took the babies with seizures who had a EEG correlate on EEG or amplitude EEG. And it was separated into electrographic only or electroclinical. And these were the predominant seizure manifestations, motor manifestations. So the motor was automatisms, clonic, epileptic spasms, myoclonic, and tonic. The non-motor seizure types were autonomic, so like apneas, or behavioral arrest, which were events that you would never know if they were a seizure without an EEG hooked up to the baby's head. Sequential seizures is when you have multiple seizure types within one seizure and there's no predominant seizure type. And then the last was unclassified. So using our classification, just like the Fisher classification, in the neonatal classification, we are always thinking of etiology. So as we're doing the workup to see what if the electroclinical or electrographic seizure types, or if they have an epilepsy syndrome, we're always looking at etiology. And the etiologies were similar to the Fisher etiologies, except we added hypoxic ischemia because that's a very common etiology in the neonatal period. And we didn't have a specific immune etiology. And the EEG is very important because it can be used as a biomarker for some of the genetic epileptic encephalopathies. So it can help differentiate whether we are dealing with an acute provoked seizure or an epilepsy syndrome. And it also can help us with seizure semiology, and seizure semiology can help us with the etiology. And it's also very important to considerations when we're determining the epilepsy syndromes. And I'll explain to you what this means, but there's a paper that is online for comment from the ILE looking at new neonatal syndromes, and they have specific mandatory features, alerts, and exclusionary features. And it helps us with the diagnosis of an epileptic encephalopathy, which I will explain to you in subsequent slides. So this is from the paper that is proposed by the ILE nosology committee looking at the different neonatal syndromes. So this is just an example of what we put down as the diagnostic criteria for self-limited familial neonatal epilepsy. So these are the three columns that I had mentioned. So these are mandatory features. Alerts are something to alert you to the diagnosis, and exclusionary would be this is not the diagnosis. So mandatory features for this type of epilepsy is it needs to be focal clonic or focal tonic seizures, which may alternate sides from seizure to seizure, which may evolve to bilateral tonic-clonic seizures. And then they gave some alerts and exclusionary for the EEG. And they did this for all of the proposed syndromes. This is the proposed classification, and it's still online, although the comments have been closed. The proposed neonatal syndromes are 3 big groups. So the self-limited epilepsies, the developmental and epileptic encephalopathies, and the etiology-specific epilepsies, which you can see there. I just wanted to say that the early infantile developmental and epileptic encephalopathy is one big group that now was previously just known as Odahara and EME. So here's the first case. I'm going to show you this background EEG, which you can see is quite a suppressed EEG. You just see prominent EKG artifact throughout the EEG. So when you see this background, what do you think of? So it can be excessive discontinuity. You have to determine when the background is invariant or if it's just a state change that you're looking at. It could be a sign of severe cerebral dysfunction or severe asphyxia. It could also be due to a massive intracerebral hemorrhage. It could be due to a severe infection or severe malformation of the brain, or it also can be due to an inborn error of metabolism. So the differential is quite large. So the first case, this EEG that I showed you is of a baby girl who was born at 39 weeks gestation to a 20-year-old mother who presented to the hospital with decreased fetal movements. She was born by emergent C-section, secondary to decreased fetal movements, non-reassuring fetal heart tracings, and meconium-stained fluid. Her APGARs were quite low. And within the first hour of life, she was noted to have some episodes of desaturation and movements concerning for seizure. She was loaded with phenobarbital and started on therapeutic hypothermia. So shortly after the monitoring started, we found this. So as you can see on the left side, there is a very nice evolving seizure background on discharge on this abnormal background. And just of note, once phenobarb can lead, once you give it, it can lead to transiently worsening the background, although you should see the baby's brain activity within the first 12 to 24 hours after the load. But this is the discharge, phase reversing at F7, and you can see it evolving and then slowing. You see it up here as well. And then you see it petering out and stopping. So clinically, this was an electrographic seizure. So this is a still, but the video looked exactly like this. There was no motor manifestations to this discharge. The baby was rewarmed, and a week after the rewarming, this was the background. So you can see there's more activity. It's not completely suppressed anymore, but it's slightly asymmetric. So this is a baby we want to closely monitor and see how the baby does clinically. So all the electrographic seizures stopped, and the baby was discharged home off all anti-seizure medications. The MRI brain was done and revealed abnormal cortical signal abnormality throughout the bilateral cerebral hemispheres. The MR spectroscopy revealed evidence of hypoxic ischemic encephalopathy with an elevated lactate peak. The baby is now 2 months old and has not had any further seizures. Second case. So this is the background of a 37-week neonate. You can see this is a burst suppression pattern. So there's bursts, and within the burst is a very suppressed record. So it's important to always know the age of the patient when reading a neonatal EEG. So when you see this, what do you think of in terms of what could be going on in the differential diagnosis? So it could be induced pharmacologically with high doses of barbiturates or other neuroactive medications, or could be due to severe brain dysfunction, whether it be a severe genetic metabolic disorder, a severe CNS infection, cerebral malformations, or post-anoxic. Some of these can be treatable with early diagnosis, such if there's a metabolic disorder that you can correct or treat a CNS infection or treat anoxia with cooling. And it could be temporary if it's due to drug intoxication, acute hypoxemia, or hypothermia. So deep hypothermia is associated with slowing and attenuation of the EEG to the point of electrocerebral silence, according to these papers, or it could also be due to a post-ictal state. Just briefly, when you see seizures in the neonate, you want to quickly diagnose and try to find the etiology so you can correct it. So shortly after you find their seizures, within minutes, you want to see if you can correct any electrolytes or glucose imbalances, and then move along the chain looking for other etiologies that you can correct and broadening your differential. So prognosis, when you see a burst suppression pattern. So in the absence of significant concentrations of neuroactive medications or cooling, a burst suppression pattern is usually associated with a very poor prognosis. And burst suppression that is sustained is associated with a poor prognosis, even with therapeutic hypothermia. And ACNS made this recommendation because they wanted to specify a non-reactive pattern to make burst suppression more prognostic for poor outcomes. So the clinical history of this burst suppression EEG is this is a 1-day-old baby boy born at 37 weeks gestation who presented in the first hour of life with focal jerking episodes. So does it matter when the seizures begin? And it does, because it definitely can help you when you're thinking of etiology. So within the first day, the common etiologies are HIE, infection, drug effects, paradoxine, other inborn errors of metabolism. And as you move along with the baby's just age, the etiologies change. And so this can help change your differential so you know what you're thinking of and can go down the appropriate diagnostic workup. So we hooked this baby up to EEG and we found this evolving seizure pattern. And you see it's evolving along the center and more C4. So in this baby, you want to use the abnormal background pattern, the seizure type, the seizure onset, and help broaden down what you think this etiology is. So we have a burst suppression EEG whose seizures begin very early on in life, look like this, and evolve, spreads to the other hemisphere, and then actually seems to continue more on the left than on the right. And clinically, this is what the baby does. So you see this irregular jerking of the left arm and of the foot as well. So based on our classification, this is most consistent with myoclonic seizures. And does myoclonic seizures help you think of the etiology? And as part of the classification task force, we looked at 128 seizures of different etiologies. And we went to see if there were specific semiologies that were associated with certain etiologies. And we found that with HIE, commonly we see electrographic seizures. And also with vascular, we see electrographic seizures and infectious. But with metabolic, we see myoclonic and also sequential. And with genetic, we typically see tonic and sequential seizures. So when you see a specific seizure semiology, think of specific etiologies. So in this baby, these seizures were refractory to multiple medications and as well as vitamins. We gave trials of multiple medications and this baby continued to be refractory. So in this case, we use the seizures, the EEG, and the onset of seizures to help us make our diagnosis. So this is from the proposed nosology syndrome paper, showing that this baby most likely has early infantile developmental and epileptic encephalopathy because of the myoclonic seizures, the burst suppression, and the early onset of the seizures. And as I said before, this syndrome was previously EME or Otahara. So we combined the two syndromes into one. This baby ended up having paradoxical 5-phosphate responsive epilepsy. And PLP is the active form of vitamin B6. So PMPO is identified as inborn error of metabolism associated with impaired B6 synthesis. It's typically inherited autosomal recessive, and it has been identified as a rare cause of early infantile epileptic encephalopathies. Most cases of B6 responsive epilepsies are paradoxine responsive secondary to mutations in the antiquidine gene. But this patient with PL needs chronic PLP supplementation to be given at a dose between 15 to 30 mg per kg per day. So I'm going to show you another patient with a burst suppression background. This is the background. You see it suppressed with just a few bursts. And you see this discharge that was associated with myoclonic jerks. And you can see in the EMG lead that there's muscle artifact with each one of the bursts. So this baby was born by normal spontaneous vaginal delivery with good APGARs to consanguineous parents. On the first day of life, he developed a progressive encephalopathy with hypotonia myoclonic jerks. The MRI was normal. So because of the myoclonic jerks, we were concerned for a metabolic disorder. And we found, so this baby had epileptic and non-epileptic jerks. And I showed you the ones that had the EMG correlate. So these didn't have an EEG correlate. And this baby had non-ketotic hyperglycemia. Third patient with a burst suppression background. Here's the background. All the bursts look slightly different, but that's okay. The burst can look like anything on a suppressed background. This baby is a 37-week baby with IUGR, microcephaly, hypertonia, and contractures. The APGARs were 7, 8, and 9. And on the second day of life, this baby had an event suspicious for a clinical seizure. Her left arm elevated and had decreased movement and appeared stiffer than at baseline. And this is the discharge that we saw. So again, it was mostly over the midline of the head, but you can see it evolving over the right more than left. And then it abruptly stops. And it goes back to the suppressed background. Clinically, this is what the baby did. So you see that the left arm is extended, the right arm's moving. The legs are kicking, but the left arm is just really stiff and not really moving and fisted. So according to the classification, this would be consistent with a tonic seizure. And she was refractory to all given anti-seizure medications. She ended up having BRAT1 gene. And as we said before, tonic seizures are commonly associated, you think of genetic etiologies. BRAT1 gene is a lethal early onset severe epileptic encephalopathy with epilepsy. The third case. So this background looks different than all the others. It's continuous, looks for the most part normal, possibly some slowing on the left, but it's kind of hard to tell from this slide. This is a 2-day-old boy born at 38 weeks gestation by vaginal delivery with APGARs 9 and 9. On the second day of life, the parent noted some rhythmic right arm jerking that was not suppressible for 2 to 3 minutes. So this description is very concerning for a clonic seizure pattern. And this is what we saw in EEG. We saw an evolving seizure pattern over the left, mostly central region. You see it evolving and evolving even more in amplitude and morphology, spreading more midline. And clinically, this is what the baby did. You see this very rhythmic jerking on the right. And so with this baby, you use together the somewhat normal background, possibly slower on the left, and this very rhythmic jerking pattern, which is as the semiology is classic for clonic seizure. And this baby, when we did an MRI, had an infarct. And so when you think of just putting everything together, when you think of clonic seizures, stroke should always be on the top of your differential. This is the last case. So this is a baby girl born at 38 weeks gestation who presented with episodes of increased muscle tone. And this is what she did. So you hear her crying.
We're not breathing now, darling. Come on, start over. Get her over.
Pick her up, and she is so stiff. She almost looks like a plastic baby. And she's no longer crying.
Oh my God. She's not breathing at all, darling.
So this baby, the diagnosis is hyperaplexia, or stiff baby syndrome, or startle disease. Hyperaplexia is not an epileptic syndrome. It can start early on in utero, and it presents with a classic triad of stiffness, nocturnal myoclonus, and exaggerated startle reflex. So you can tap their nose and they get this excessive startle. It's autosomal dominant with 100% penetrance, but it also can be sporadic. And you can do the nose tap to bring it out. And typically it resolves with the Vigevano maneuver, which is where you bend the neck of the baby slightly to relax the baby. You do, typically the workup is with EEG, EMG, genetic testing, and it can be treated with benzos, but also clobazam, valproate, or vigabatrin. So in summary, the neonatal classification for seizures can aid in determining the etiology of the seizures. Most neonatal seizures are acute provoked or acute symptomatic seizures. The ILAE has developed a new classification of neonatal syndromes, where the EEG can be helpful in determining genetic epileptic encephalopathies. And this is the proposed syndrome classification that is online on the ILE website. Burst suppression, as I have shown you, it can be due to many causes, and the prognosis will depend on the etiology. Some have better outcomes than others, and not everything that stiffens or shakes is a seizure. So an EEG is very important in this period. Thank you so much for your attention.
Oh, thank you so much. That was a really nice spectrum of cases with seizures of all different etiologies. I really like the beautiful evolution of the seizure in that baby with the stroke that you showed. I thought it was a nice contrast to one of the earlier seizures we saw in Jeanette's presentation earlier with the KCNQ2 baby, which had a kind of not quite as smooth of a crescendo decrescendo in that seizure. And certainly you can see that in some of the epileptic encephalopathy babies, not as smooth of an evolution. We have a number of good questions in the question and answer. We'll turn it over to you.
Sure. So the first question is, for seizures in the setting of HIE, how long should we continue the anti-seizure medications after the seizures stop? So this is a really good question, and a question that we really had no guidance on until recently. So everybody kind of did different things. The majority of the clinicians stopped it prior to going home, but some would get nervous, especially if they were very hard to treat, or if they had an abnormal EEG or things like that. And we didn't really have much guidance on what to do. And it also kind of depended how brave you felt before sending the baby home. So recently, there was a publication from the Neonatal Seizure Registry showing that it really doesn't matter. Treating with or keeping them on anti-seizure medications doesn't prevent you from getting epilepsy. So typically what I do is I stop it prior to the kids going home, even if I'm nervous, if the EEG is still looking ugly, or if they were really hard to treat, I still slowly take it off, and typically they're off before they go home.
Yeah, I'll open it up also to our other panelists.
Yes, because this is like a big area of debate in all the committees I'm on.
That's what I do, the same thing. I mean, the study from Hannah Glass and the team, I think, I feel like we have been doing that for a while, but I feel like with much less comfort in a way. Like I would do that, but I worry, but I feel like we should do that. But now I feel like we at least got that kind of evidence we needed to say, yeah, it's okay to try. I feel the same, Alisa. Exactly. I feel a little nervous, but I do that too.
I know we have other panelists that feel also would like to chime in.
Yeah, we looked at this a long time ago with regard to which children after neonatal seizures go on to have epilepsy, and found no difference in the kids that were stopped right away versus later. Now, those were clinical decisions. That was not a randomized control trial. So it could be that if the kids had mild seizures, people were happy to stop early. But the fact remains that, like, continuing on the neonatal anti-seizure drug does not protect you from developing infantile spasms later or just plain vanilla epilepsy.
Yeah. Ilana?
I agree. I try to do the same thing. I try to wean them off before they go home. But at our center, it's still between different neurologists. The practice still varies a bit. But usually even the ones I'm a little bit more scared, I try to wean them off slowly before they go home.
Yeah, we've actually sort of imposed on our group within 5 days of when the seizures stop after provoked seizures. Obviously none of us would stop seizure medications if we thought the baby had one of those rarer cases of neonatal onset epilepsy that you've heard about in this presentation. But for provoked seizures, typically at around 5 days, we start pulling off one medicine, and then 6 days, the second.
Sure. If the baby has neonatal seizures from TS, they're just starting their career in seizures, and no way you're going to stop it then. But the one and done acute reactive seizures, yeah, we try to stop them.
Yeah. Great. And yeah, we appreciate that everyone feels nervous, because we've all been through that. But definitely like to stop those medications. There's another question that's sort of related. When do you consider sending genetic and metabolic tests in neonatal seizures?
So when I don't have a clear etiology, or if the seizures aren't stopping right away, or if they have more of a tonic seizure, a sequential seizure, or a myoclonic seizure, it makes me think more genetic metabolic. And in those cases, I'll send it off sooner rather than later. I like, now that I'm more aware of the clinical semiology with etiology, it really is true in a lot more of the babies than the 128 that we looked at. I see it every day.
Yeah, I
agree. And sometimes I find also if they have a HI and it's milder and it just don't behave the way I would expect it, even in some of those HI, I sometimes send it if I feel like this is not okay. But I agree, actually.
Right, that's a good point.
It's also much easier to send genetic tests from the hospital than it is from the outpatient clinic. I mean, just a survival feature.
That's true. Although that behind the seizure panel makes it a little easier. At least it's it's not costly these days.
Yeah, yeah.
So we've had two questions now about why are neonatal seizures more often midline?
So it depends on the age, but in preterm babies, the most common cause of seizures is bleeding, IVH, and that's all midline. As they get older, the more in term, it's more HIE. But I just attribute it to that. It's the midline is where the damage is, or the irritability that's causing the seizures.
Yeah, I don't know that it's true, really, that the most common location is, FC, CZ, PZ. I mean, the watersheds in partial prolonged asphyxia are parasagittal, and that will include, the midline. But I think central temporal is the most popular place for, like HIE kids to have a seizure.
Yeah, and at least the published studies seem to indicate exactly as you said. It is true that you can see seizures in a neonate at CZ more often than you might in an older child.
Right.
But it's not the most common seizure location for us to see in a newborn.
Right.
And then I had a question about whether it's okay to have activity above 5 microvolts in the burst suppression patterns in the babies with a genetic epilepsy, epileptic encephalopathy.
So I think so. I think if it's otherwise invariant, so burst suppression by definition is less than 5 microvolts, and that's what I teach the fellows. But if it's otherwise invariant, having these typical intractability and is acting like a burst suppression EEG, I would call it. I think going along the same rule as the 10-second seizure pattern, like everything's a continuum, and you just have to go with the overall gestalt.
Yeah, and it seems like it's a slightly different kind of a burst suppression pattern in those genetic epilepsies as opposed to our HIE babies with burst suppression. Just because those bursts are such high amplitude as you showed, whereas our HIE acute severe HIE babies tend to be moderate to low amplitude bursts. So yes, there's room for improvement in the terminology. Let's see. Oh, extreme excessive discontinuity was a comment. So yes, with the current definitions, you would if you were to use ACNS terminology, you would say very abnormal discontinuity. But probably there should be some modifications for this other type of a burst suppression pattern. And I think we've got all of the questions. Thank you very much to all of our panelists for chiming in.
I mean, may I ask you, Dr. Clancy? Dr. Clancy, may I ask you one question? If you have a term neonatal, all you have is in sleep a little longer. You have alternate. You have either discontinuous. If you simply have a little longer discontinuity in the term neonate in sleep, what do you make out of it?
Oh, I mean, from a pure EEG point of view, you would say, well, you don't fit the criteria, so I can't call you completely normal, so I'll call you mildly abnormal. But usually that means nothing in terms of prognosis. So, it's like if you're an umpire at a baseball game and the pitcher throws a strike, you got to call it a strike, you know. So, yeah, you call it and then you hedge in the report like this has no clear-cut prognostic significance. I love my president, all this fluffy baloney talk, and then you sign the report. Yeah. But it's like the question of if you're doing long-term monitoring on a preemie and one single burst is 60 seconds, do you focus on that 1 minute or the rest of the EEG?
Yeah.
So it's like, yeah, if there's like a few periods of long interbursts, but everything else looks well, in your heart, I think you would believe that this kid's okay. Even if from just diagnostic criteria, you're compelled to say some of the bursts within quiet sleep or excessively low voltage or long for a child of this PMA. However, your results may vary, that kind of thing.
Thank you. That's what kind of I had the same feeling, but I just wasn't sure if I was simply just brushing too much.
Yeah, it tends if you're a lumper or a splitter. I try to look at the big picture as best as I can rather than like focus in on this 1 60-second period. Because I don't know, maybe the kid's constipated. God only knows,
Thank you.
You're welcome, Jeanette.
Yeah, thank you. Yeah, I love having more than a routine EEG to review.
Yes. Well, one thing you got to realize is that a lot of these criteria were based on routine EEGs. Now, a typical routine neonatal EEG might be 45 minutes or an hour, longer than the kids get in a routine, outpatient EEG, but it wasn't much more than an hour. So all you can say is within this hour, here are the interbursts, here are the sharp waves, here's the flat periods, whatever. And then when you start doing monitoring, you realize there's a whole lot more variability than you can detect, of course, on a 1-hour EEG.
Yeah. Great point. Well, thank you again to our panelists, and we have more great cases. So I'll move on to Dr. Ilana Pinchevsky. She is an assistant professor at I might mispronounce this, St. Justine Hospital in Montreal, Quebec. She's a neonatal neurologist with a particular interest in the effect of hyperglycemia on neonates with HIE. She'll be sharing her expertise live with some great cases and has some poll questions that you'll answer in the Zoom window.
So I'm going to try and share my presentation. Give me one sec. There we go. Do you see my slides?
Not yet.
Nope. One sec. There we go. How about now?
Yes.
Perfect. So we'll start off. So the objective of these next cases is to improve our understanding of the use of EEG monitoring for seizure identification and treatment in newborns, and further develop our understanding of how EEG background can aid in prognosis and management. So we'll start off with the first case, and remember there are poll questions, so you'll need to participate and let me know what you think as we go through the cases. So we'll start off with our first case. You're consulted to the neonatal ICU. It's a 7-hour life baby girl. When you review the chart, the prenatal history was uncomplicated, but mom did take aspirin and Fragmin because there was a history of preeclampsia and premature birth in the first pregnancy. She presented at 38 weeks and 5 days with severe preeclampsia. There was an abnormal fetal heart rate tracing, so baby was born by urgent cesarean at 4:20 a.m. APGAR scores were low at 2, 3, and 5, and she required positive pressure ventilation and was intubated early on. Unfortunately, the cord gas was coagulated, but you had a gas at 1 of our life with an OK pH at 7.21, but a base excess of -19 and a lactate over 12. The physical exam was consistent with moderate encephalopathy, so modified Sarnat score of 2. And with this history and exam compatible with hypoxic ischemic encephalopathy, therapeutic hypothermia was appropriately started before 6 hours of life. There was no concern at all for clinical seizures, but at our institution, we started continuous EEG monitoring and all these babies undergoing therapeutic hypothermia as soon as possible. So we started at 8 hours of life. And a few minutes after it started, the EEG tech calls us to please look at the EEG. So we open up the first page. So just to orient everyone, this is a neonatal bipolar montage. In blue is the left, in red is the right. And we're going first on the parasagittal here, and then the left temporal, and then on the right. And then we have the midline electrodes in black, and then transverse bipolar from left to right. So here the EEG started at 12:20, so baby's about 8 hours old. And on this first page, we see in the left central temporal region, this high amplitude, about 1 hertz spike wave patterns, and sometimes with the appearance of this overriding polyspike pattern. If we go to the next page, we still see this pattern. So on the video, I didn't see any clinical movements noted. So we'll go forward and we can kind of appreciate now some evolution in the location. It's involving the frontal regions now. And we'll page forward for the first few minutes of the EEG together so you can decide what you think. We can see a bit of evolution in morphology, a declining frequency, but it picks up again shortly after. And now we see some evolving delta activity also on the right, independent of the left. So now we'll start with our first poll question. So they want to know what you think of the first few minutes of this EEG. So I'd like you to decide, do you think it's a seizure? Do you think it's rhythmic or periodic activity? Are you not concerned for seizures at all? Or you're kind of not sure, you're on the fence between seizure and not seizure, and you want to call a friend? So I'll give everyone a few more seconds and then we can close the poll. I don't know if I'm able to see what everybody voted. I can't see, but we'll, I hope you all voted. And we'll go to the next slide. So this one, the pattern was there from the start. So it's a bit hard to appreciate the evolving crescendo decrescendo pattern. Oh, there it is. We have 71% who thought it was a seizure. About 30% thought it was rhythmic and periodic activity. Great, so this one was a bit hard, as we saw, because it was there from the start. So it's hard to appreciate an evolving crescendo decrescendo pattern and that sudden start that we talked about that usually defines a seizure. But I hope we can, as we go through, we can convince people that there is a buildup in evolution and morphology, as well as frequency and location. Although I do agree it's somewhat of an odd pattern, but there was definite evolution. So a load of phenobarbital was started. And we'll go forward here, and we see this rhythmic pattern is still there. It's slow, but neonatal seizures tend to discharge at a rate of 1 to 3 hertz, although sometimes faster. They do tend to be in the lower end of the range. And here we can see discharges independently started from the opposite hemisphere at a different frequency. And although seizures may spread sometimes to the opposite hemisphere, because the neonatal brain is poorly myelinated, you can also see independent simultaneous onset in the opposite hemisphere that can give this appearance we see here. And we see both hemispheres, these discharges evolving and changing in morphology, as well as frequency and amplitude. Here I fast forwarded another 15 minutes. So we can finally now try to appreciate that declining or decrescendo pattern, first on the left and then on the right. So now our phenobarbital perfusion has finally just completed, and we're over 30 minutes from the start of our EEG. We don't know exactly how long this seizure has lasted because there's absolutely no clinical correlate and no clinical suspicion of seizures. So it had at least over 30-minute duration. When we go forward, we see that rhythmic pattern has finally stopped, but 2 minutes after, a rhythmic pattern seems to start again, now in the right frontal region. Now it kind of becomes this right frontotemporal slow delta pattern. It's kind of lower amplitude, more focal slow activity that's kind of slowly evolving and building up in the right frontotemporal region. And then we see it gradually slow down and stop. Shortly after, we now see some low amplitude rhythmic, sharply contoured delta in the left temporal region. On the next page, this low amplitude rhythmic delta kind of becomes more sharply contoured. And if we move forward 3 minutes later, here I've changed the sensitivity so we can get a closer look. And on the left sensitivity scale bar is now at 25 microvolts, not 50. And we can see that right temporal region, there's some rhythmic activity that's low in amplitude. And on the following slides, we'll see kind of evolves, but sometimes waxing and waning over time. We see evolution in the morphology, but sometimes more rhythmic slow waves, rhythmic sharp waves. And between these episodes of rhythmic patterns, there's low amplitude of the background with some high amplitude bursts of activity. So now our second question, what do you think of these low amplitude rhythmic patterns? We'll open up the polls again. Do you think these are seizures, not seizure, or you're not sure? So I hope everyone has voted and we can move forward. I don't know if the answers are going to pop up again. There we go. So about 80% thought they were seizures, 7% thought not seizures, and we've got 14% who aren't sure. So for all those who aren't sure, let's keep looking. So now we're about 4 minutes later, and here in the left temporal region, we can start to see a rhythmic pattern come back. It's kind of evolving. It's now on the right as well, and we'll continue moving forward. We can see it slowing down. So now we see these subtle evolving patterns that continue. We've looked over the past few slides over 25 minutes of EEG, and we've really seen multiple episodes now that keep coming back. So after we continue to look, I want to ask again what people think. Do they think these are seizures, not seizure, or are you still not sure even after these further episodes? So we'll close up the polls and see what people think. So now we've convinced a few more people. The majority think they're seizures, but we have a few who think, still 6% think they're not seizures. So although they were slowly evolving and subtle, because there were multiple episodes in this case, we did think they were seizures. But if you weren't sure after the first one or two with a slowly evolving pattern, we kept looking, and then there were kind of many of them, and enough to convince us to give some more phenobarbital. And although they're low amplitude, the minimum for seizures is to be at least 2 microvolts peak to peak repetitive and evolving patterns. So they were above that cutoff. So we decided to give some more phenobarbital. And the rationale was that seizure recurrence after anti-seizure medications can be lower amplitude, more focal, and more often electrographic only. Then we saw that after we gave our phenobarbital, the rhythmic pattern was no longer there. However, when we fast forward another 3 hours, we start to see some periodic delta activity coming back, independent over the left and right temporal regions. And as we move forward, we can see it changes to rhythmic delta. Check the video, there was no clinical manifestations. And as we go forward, we see a buildup of these sharply contoured slow waves. And this is more evident than those low amplitude ones we'd looked at before. And as we move forward, we can see that clear decline in frequency, first on the right and then on the left. And shortly after that episode, we see another example of this slow activity that's kind of building up and evolving. And now here on the right, we can see that the seizure pattern is clear spikes and not just that sinusoidal delta. Here we see a clear evolution, both in frequency and voltage, as well as morphology. And now we see that nice clear decrescendo pattern at the end. And so these have been going on now for the last 10 minutes. So we gave another load now of levetiracetam, 60 milligrams per kilo. The G went back to that low voltage activity, but about an hour later, we start to see some rhythmic activity now starting in the left frontal region, which I'd like you to take a look at over the next few pages so you can tell me what you think of it. So it lasts about a minute and a half and then it stopped. So next poll question, do you think this activity was a seizure, not a seizure, or you're still not sure? So we'll close the polls and see what everyone thought. So 67% thought they were seizure, 13% not seizure, and 20% weren't sure. So I agree, this one was a bit less clear, but there was clear evolution and we thought it was a seizure. Whoops. So we did give another load of phenytoin. And after that, there was no more of these rhythmic patterns. We checked the EEG again before going to bed at 11 p.m. There's no more periodic, no rhythmic activity, no seizures. The background is very discontinuous with prolonged interburst intervals. The next morning, there was no further seizures. We check again in the afternoon. And here we can see now some rhythmic activity coming back. But this time, when we see this rhythmic activity, it's over the both posterior regions. And on the video, we now saw clinical correlate. There was tonic extension of the left arm and leg. It slowed down gradually and came to a stop. So here, because we had an electroclinical seizure, we gave another load of phenytoin. And this seizure was 14 hours after that last seizure we looked at. So as a take-home message here, phenobarbital is often effective within an hour of loading, but that effect can wear off and the seizures can return within 1 to 9 hours after treatment. So it's important to keep monitoring. So here's after we finally calmed down the EEG. There's no further seizures, but he's received a lot of medications. So to better appreciate the EEG background, let's move forward to the third day of life. He's completed his cooling and he's now being rewarmed. And we see a persistently low voltage of the background activity with amplitudes kind of between 5 and 15 microvolts, but no normal features. And this is really the only pattern we see. There's no state changes observed. Sometimes we have some low amplitude bursts of activity, but they're less than 2 seconds. So now the question is, what do we think of this EEG background and how would you characterize it? Do you think it's abnormally discontinuous, a burst suppression pattern, or a low voltage suppressed background? Or you're kind of not sure, you're stuck between two of these options, or you have no idea because the background in babies is very different from children and adults. So we'll close the polls and see what everyone thinks. So we've got an array of answers. Some vote for abnormally discontinuous. We've got about 20% for burst suppression and 44% for low voltage suppressed. So this one was hard. So let's go back and take a look. We do have some pages where there's really no clear activity above 5 microvolts, which is characteristic of the burst suppression pattern, because as the ACNS definition, as we talked about, a burst suppression is invariant, abnormally composed EEG bursts separated by prolonged and abnormally low voltage IBIs that are defined as less than 5 microvolts. However, we have some other pages where there's low voltage undifferentiated activity, always without any normal features. But we can see, such as here in the left central and right temporal region, some low amplitude delta activity, which would be characteristic more of a low voltage suppressed background. which is defined as low voltage activity without any normal background features. And the fundamental baseline voltage is below 10 microvolts peak to peak, but above 2. And the background can sometimes be interspersed with those higher voltage transient activity, but for less than 2 seconds, as we saw. And in addition, the recording's going to be invariant and unreactive. But as you see, sometimes not all pages fit nicely in one category, so I think it's okay if we weren't sure on this answer. Throughout the monitoring, the background remained the same without any state changes noted, and we really had persistence of this low voltage suppressed background, which is often associated with a poor neurologic prognosis. MRI was done after the baby was rewarmed on day of life 4. Here we have diffusion weighted images on the left, the DWI and ADC, the apparent diffusion coefficient maps here on the right. On the DWI, white is bad, ADC dark is bad, and we can see diffuse cortical involvement, which is often called the white cerebrum pattern, because the pattern shows it's almost diffusely white with relative sparing of the cerebellum. And as we go up, we see diffuse cortical involvement, including involvement of the basal ganglia. So there was a poor prognosis with this pattern, and care was redirected. So just a brief word on how the EEG can aid us with prognostication. So there are several studies that have shown that background patterns associated with adverse neurodevelopmental outcomes include low voltage suppressed electrocerebral inactivity and burst suppression patterns, and particularly when these patterns are persistent or they worsen with time. Also, if there's failure to develop sleep-wake cycling, particularly after 48 hours in newborns undergoing therapeutic hypothermia, is associated with worse outcomes. Also, seizures are also associated with worse outcomes, particularly higher seizure burden. And there was a nice study that showed total seizure burden over 40 minutes and a maximum hourly seizure burden over 13 minutes per hour is associated with worse outcomes, as we saw in this case. So our next take-home message to remember is that EEG monitoring can be useful for detecting seizures, but also for prognostication. And to remember that 50 to 80% of neonatal seizures are electrographic only and would go undetected without EEG monitoring, such as in our case. And we've talked about this a bit, but this case is also a good illustration that sometimes we're not sure, such as with those short, low amplitude rhythmic patterns. So you can kind of continue to check the EEG and see how those patterns evolve to become more convincing with time in the goal of avoiding overtreatment. And sometimes we may opt to treat even if we're not entirely sure. But if the pattern in the clinical picture doesn't improve, then therapy shouldn't necessarily be escalated, similar to what is done in older children and adults when there's that ictal-interictal continuum. So let's now move on to our second case. So our second case is also in the neonatal ICU. You review the history. It's a 32-year-old mom, G2P1. The second trimester echo showed that there was ventriculomegaly and macrocrania. In the third trimester, the ventricles now appeared normal, but there was polyhydramnios. They did do an amniocentesis, and there was a normal chromosomal microarray. Mom came in for an induction at 38 weeks and 5 days for that history of macrocephaly, but because of an abnormal fetal heart rate tracing, he was born by cesarean with a birth weight over 3 kilos and a head circumference of 34 centimeters, so it was normal. APGAR scores were low at 1 and 5 minutes, but with some positive pressure ventilation picked up at 10 minutes. Cord gas was okay with a pH of 7.16 and base excess of -9. They noted the baby was hypotonic, had arthrogryposis and respiratory distress, so they transferred him to the neonatal ICU. Clinical exam was consistent with mild encephalopathy, so modified SARNet as 1, so he didn't qualify for cooling, but they did note he had severe refractory hypoglycemias for the first 4 days of life, even below 0.6 millimoles per liter or 10.8 milligrams per deciliter. Neurology was consulted on day of life 2. They described him as very tremulous with axial hypotonia and appendicular hypertonia. So they requested an MRI brain. Genetics saw as well. They wanted to do a gene panel. You got your MRI the next day. We have T1 images on the left, T2 on the right. And we see on T1 posterior hypointensity and corresponding hyperintensity on the T2 imaging that was suggestive of bilateral occipital edema. As when we looked at the diffusion weighted imaging here on the left, ADC maps on the right, it There was no clear restricting diffusion posteriorly, but there was some restriction in the posterior limb of the internal capsule, as well as some punctate white matter injury in the frontal region here, which is consistent with mild HIE, as well as some hypoglycemic injury. However, on day of life 5, this baby has a temperature of 38.5. He's now hyperglycemic, requiring insulin, and he had increasing respiratory distress. But when you delve a bit further, this respiratory distress is described as brief apnea and desaturations, and sometimes they note some clonic movement with them. So they wondered if these could be seizures and requested EEG monitoring. They did do an LP with that temperature of 38.5, which was traumatic with over 56,000 red blood cells and 400 white blood cells, but that's still more white blood cells than we expect for that amount of red blood cells, so he was started on meningitic coverage. And now let's take a look at our EEG. To orient everyone, it's that same neonatal bipolar montage. This is our first page. We do see a few sharp waves here coming in the left occipital region, and then this burst of theta activity. And if we go to the second page, we see some subtle evolution, not that clear crescendo, decrescendo we've seen in some of the other nice seizures. But when we open our video, we see it's associated with a brief apnea. Between these bursts of activity, we see a low amplitude background interspersed with these high amplitude bursts of activity. So the NICU wants to know, what do we think are these brief episodes of apnea? So we'll open up our next poll question. Do you think these episodes of apnea are seizures? On the EEG, are you seeing rhythmic or periodic activity? Are you not concerned at all for seizures? Or are you not sure, you want to keep looking, or you have absolutely no idea? So now I hope everyone's voted, and we'll see what everybody thinks. So we have 80% who think they're seizures and 13% aren't sure, and about 7% think they're rhythmic and or periodic activity. So let's look forward. Very shortly after that first episode, we have a second one. And so we see there's not always a clear evolution, but there really is clinical accompaniment. And thus these were judged to be electroclinical seizures, although they don't have all those nice classic electrographic features you heard that we should be seeing with seizures. We do see that there's kind of a burst of delta followed by some 4 or 5 hertz theta activity that's associated with the apnea. So there is clinical accompaniment. And here I decrease the sensitivity to 30 microvolts. And you can see that there's some theta that evolves now at the end to 1 to 2 hertz sharp waves. And as you've heard earlier, seizure events should start and suddenly stop, and they should evolve and stand out from the background. And here we also have a clinical correlate. So let's also take a look at the video with these events. So we don't have the sound, but there is an apnea. And then he has some faster respiration when he starts to breathe again. Then you can kind of see behind Dad's arm, when it slows down to that 1 to 2 hertz activity, we see some clonic movements of the arms. And then it stops. So these were considered electroclinical seizures, and we have over 100 seizures in the first 5 hours of monitoring. In those 5 hours, he received phenobarbital 40 milligrams per kilo and levetiracetam 60 milligrams per kilo. Now you take over call at 6 p.m. NICU calls you that he's still having apneas. On the EEG, you still see these same bursts of activity. So you decide to give some phenytoin 20 milligrams per kilo. Then you get some more calm EEG. You have these bursts of activity that are around 150 to 250 microvolts. And between these high voltage bursts, you have interburst intervals at about 10 to 20 microvolts. And here I've compressed the time scale so you can really see how long that period is between the interbursts. So here there's 60 seconds on a page. So you can appreciate that these interburst intervals are over 60 seconds. There was sometimes a little bit of reactivity with more theta and delta seen in the bursts, but there was no spontaneous state changes noted or sleep-wake cycling throughout the day. So now the next question is, how would we characterize this EEG background? Do you think it's abnormally discontinuous? Would you call it a burst suppression? Would you call it low voltage suppressed? You're not sure, you're stuck between two of these options, or you have no idea. So now let's see what everybody thought. So we have the majority, 46% think it's a burst suppression, 30% voted for abnormally discontinuous, and 23% for low voltage suppressed. So let's go back and take a look and discuss this a bit further. So we've talked a bit about this in the previous presentation. So the ACNS defines burst suppression as really being invariant with IBI voltages below 5 microvolts. So we don't meet that ACNS definition, but the French definition of burst suppression, in particular in epileptic encephalopathies, includes patterns with high amplitude bursts of abnormal activity, including epileptic discharges and fast activity separated by periods of attenuation or suppression. So we don't have burst suppression as defined by the ACNS, but we do have a type of burst suppression type pattern that may be seen in epileptic encephalopathies. As we go forward to the next day, there was no seizures seen till the next afternoon at about 3 p.m. We continued to have interburst intervals over 60 seconds. But we start again. So here on the next page, we see in the central temporal region on the right, some buildup of activity with some change in morphology and frequency and a clear offset. Not long after, we see another rhythmic pattern coming in the left frontal region. And we had multiple more episodes consistent with electrographic seizures. So we tried some more phenytoin, which had worked previously. We get briefly back to this very discontinuous pattern, but didn't last very long. Shortly after, we had recurrence of seizures. So here we have in the right central region, some rhythmic sharp waves. And although under the smoothest evolution, we do see there's that rhythmicity and evolution over time. And there was multiple seizures that continued to occur. We tried more boluses of phenytoin, had good levels, but seizures continued. We tried topiramate, the perfusion of midazolam, lacosamide. We started carbamazepine, then the ketogenic diet, threw in our vitamin cocktail, including pyridoxal 5-phosphate, folinic acid, biotin, and thiamine. But seizures continued at a rate of about 0 to 12 seizures per hour. So now, based on this EEG and clinical evolution, the question becomes, what do you think the etiology is? Do you think it's consistent with hypoxic ischemic encephalopathy, secondary to the severe hypoglycemia, an infectious etiology, or do you consider metabolic disorder or genetic epileptic encephalopathy? So I hope you all voted, and we'll take a look and see what people think. So no one thinks we can explain this all by hypoxic ischemic encephalopathy. 15% consider it might be secondary to the severe hypoglycemia, 8% infectious, and we've got about 40% each for metabolic or genetic epileptic encephalopathy. So to help us, we did repeat the MRI on day of life 10. So here we have T1 imaging on the left, T2 on the right, and we can compare this to remember the previous MRI that was done on day of life 3. Now it's become posterior laminar necrosis, which is suggestive of hypoglycemic injury. We saw that same punctate white matter injury we'd seen on the early MRI, suggestive of hypoxic ischemic injury. And the radiologists describe accentuated cortical subcortical differentiation, as well as a heterogeneous appearance of the basal ganglia. On the spectroscopy, there was low NAA, but normal choline and creatine, suggestive of metabolic disorder. So now, when we consider those etiologies, the clinical picture was initially mild HIE and hypoglycemia, but then we had those apneas and refractory seizures starting around day of life 5 with a persistently very abnormal background. So I don't think we can explain the entire clinical picture by HIE or severity of the hypoglycemic injury on our MRI. And metabolic and genetic epileptic encephalopathies really moved to the top of our differential, which was at the top of everyone's who voted as well. As we go through the next few days, our interburst intervals remained at 30 seconds to 5 minutes, and he started to really have frequent episodes of these characteristic seizure events. So we see here on the video, we can see some chewing movements. And then there's an apnea, and he desaturates, and his lips turn very blue, which is hard to appreciate in the video. And there's some eye deviation to the right. On the EEG, we still have those bursts of 6-7 hertz theta activity, which become more rhythmic sharp waves and evolve after to 2 to 3 hertz delta activity. You have very significant desaturations with these episodes, sometimes below 30%, and they would pick up and recover on their own. So now let's move forward to day of life 43. He's ready to go home, still having about 20 seizures per day. Our metabolic workup has all come back normal, including CSF lactate, amino acids, and neurotransmitters. Genetics sent off whole exome sequencing and mitochondrial DNA, which are still pending. His anti-seizure medications include carbamazepine, levetiracetam, and clobazam, as well as his vitamin cocktail. He's been weaned off the ketogenic diet, phenytoin, and topiramate. After discharge, you get back your genetic results, which show an SCN2A gain-of-function mutation. So he had an SCN2A-related early infantile epilepsy. And this case is another example of how having the genetic diagnosis can help, because the SCN2A gain-of-function mutations tend to respond to high-dose sodium channel blockers. So genetic testing can help us guide our choice of anti-seizure medications. This case was also an example of when the severity of encephalopathy on our EEG doesn't match the history and clinical exam. It's a clue that it's not acute injury and suggests an underlying chronic disorder that could cause encephalopathy at delivery, such as in this case, as an epileptic encephalopathy. I'd like to thank the patients and their families for letting us present their videos, and thank you all for listening.
Thank you. I think it's great. I know we're running over time. We got to thank you in the comments, and I really appreciate all of our speakers for giving us a great foundation in neonatal EEG interpretation, identifying seizures, and knowing clinical features of seizures that can help you in treating our babies with seizures, as well as giving you great examples of both the background for prognostication and different kinds of seizures in different settings. I've got another thank you in the Q&A. So worth staying over 5 minutes, 7 minutes. So again, thank you all, and thanks to the attendees for staying over a little longer. Enjoy the rest of the meeting. There are more courses to come. And a reminder also that the courses will be available on demand. If you happen to have to step out to do something during one of the lectures, you will be able to access them on demand. All the details for that are on the ACNS Fall Courses website. Thanks, everyone. Good seeing everybody. Bye-bye.